Namaste everyone. I am going to solve RGUHS 2021 question paper in that first short note Candidiasis. Candidiasis is an opportunistic infection caused by Candida, a yeast-like fungus. Candidiasis occurs most commonly as secondary infection in immunocompromised individuals. Synonyms of candidiasis include candidiosis, moniliasis, and thrush. These are common inhabitants in oral cavity, gastrointestinal tract, vagina, penis, or other parts. They become pathogenic only when favorable conditions arise. It can affect the oral cavity, vagina, penis, or any other parts of the body. Candidiasis affecting the mouth is commonly called thrush. Although Candida albicans is most prevalent etiology of candidiasis, there has been significant increase in non-candida species in recent times. It is important to know about non-albican species as treatment depends on that, and certain medications like commonly used non-albican candidas may be resistant to fluconazole. Among the Candida species, Candida albicans was the most common species, followed by Candida lusitaniae, Candidae parapsilosis, Candida glaberta, Candida kaffir, Candida femita, Candida africana, Candida orthopsiolosis, respectively. Is an opportunistic fungal infection, that is, they became pathogenic only when favorable conditions arise. It is caused by yeast-like fungus known as Candida, as I discussed already, and most commonly by a specific species of known as Candida albicans. Candida albicans are normal gut inhabitants living in various sites of the body, including gastrointestinal tract, respiratory tract, and vagina and mouth. They are dimorphic fungi existing in both mold and yeast forms. They are strictly aerobic, utilizing oxygen in its metabolisms and growth. Therefore, it is highly adaptive to the human mucous membrane. Their growth is naturally suppressed by other normal microbiota, but when these microbiotes are disrupted, Candida multiplies rapidly, producing candidiasis disease. They have also been found to commonly live in hospitals, causing nosocomial blood infection in hospitalized patients. Transmission of Candida albicans. Besides being a normal floro, it is transmissible fungal pathogen. Some modes of transmission include mother to infant transmission through childbirth, remaining as normal microflora unless there is an overgrowth which can result in symptomatic disease, hence candidiasis. Child to mother transmission during breastfeeding, whereby the candida on the child's tongue, mouth, or binds to the breast nipples on the mother during breastfeeding. Sexual transmission is a form is rare, but it can occur, and it has been listed by CDC as a sexually transmitted disease. Nosocomial transmission, whereby immunocompromised patients acquire the yeast from healthcare workers from invasive devices such as catheters and respirators. They account for 10% of nosocomial bloodstream infections. Based on these virulence factors and the site of colonization of the fungal agent, Candida infections can be classified as follows. Mucosal candidiasis affects the mucosal lining of the host, such as oral candidiasis, candidal vulvovaginitis, gastrointestinal candidiasis, And respiratory candidiasis. Cutaneous candidiasis affects the skin pores, and nails. For example, candidial folliculitis, candidid, chronic mucocutaneous candidiasis, congenital cutaneous candidiasis, diaper candidiasis, candidial onychomycosis. Systemic candidiasis affects the deep seated organs and the bloodstream. For example, candidemia, a form of fungemia that causes sepsis, invasive candidiasis, chronic systemic candidiasis. Antibiotic candidiasis is also known as iatrogenic candidiasis. In this chart, you can see different types of candidiasis. Pathogenesis of candidiasis. Candida albicans colonization of the host is based on the virulence factors it elicits, making it adherent to the host organ systems. These virulence factors include dimorphic nature of the Candida albicans. It exists as both mold and yeast from presence of adhesins and invasins LC3 proteins that enable to attach and invade the surface. They also form biofilms during adherence, which enables it to survive and thrive on the host. They also secrete protease, phospholipases, and lipases, which allows it to penetrate into the host cells. Histopathology. Candidiasis secretions present spongiotic changes in the epidermis with irregular acanthosis, mild spongiosis, and inflammatory changes. The distinguishing feature of the superficial epidermis is the presence of neutrophils in the stratum corneum and upper layers of the epidermis. A small collection of neutrophils, spongiform postulation, may form which resembles impetigo or psoriasis. Clinical manifestation of candidiasis. Candidiasis infection affects the cutaneous layer and the mucous membrane, which provides suitable conditions for growth. These manifestations affect the mouth, skin, vagina, and intestines. The most common types of candidiasis include cutaneous and mucosal candidiasis. This infection is most common among the persons who are immunocompromised, including AIDS patients, pregnant mothers, diabetes, infants, and children, women on birth control pills, and trauma patients that burn maceration of the skin. Oral candidiasis is also known as thrush or oropharyngeal candidiasis is the most common cutaneous and mucous candidiasis affecting the mouth cavity. It majorly affects newborns who acquire it from the mother during the childbirth, whose vagina is infected with Candida albicans. The fungi colonize the upper respiratory tract of the newborn during the passage through the birth canal. Normally, when newborns are born, they do not harbor any microbiota, which allows Candida albicans growth. This enables fungi to thrive and grow without competition or inhibition. Thrush occurs on the tongue, lips, gums, or the palates, causing patchy to confluent whitish pseudomembranous lesions made up of epithelial cells, yeast, and pseudohyphae. Other risks of developing oral thrush include treatment with corticosteroids and antibiotics, high glucose levels, and cellular immunodeficiency. Another common cutaneous and mucosal is candidial vulvovaginitis. This is a yeast invasion of the vaginal mucosa characterized by irritation, pruritus, pruritus, vaginal discharge. Those at risk are pregnant women, diabetic patients, and persons taking antibacterial drugs. These factors alter the normal microflora, local acidity, and secretion. Other forms of cutaneous and mucosal candidiasis include skin invasions that occur due to the trauma, such as burns or surgical wounds. Intertriginous infection occurs in moist, warm parts of the body such as axilla, groin, and intergluteal or inflammatory glands. It is most common in obese and diabetic individuals, forming red and moist vesicles. Onychomycosis is a candidial invasion of the nails and nail plates, causing painful erythematous swelling on the nail fold, which resemble pyogenic paronychia, which destroys nails. Systemic candidiasis. This is also known as candidemia. The most risk patients are which has the invasive device such as catheters, surgery patients, intravenous drug invasives, invasive drug abusers, respiratory patients, skin abrasions such as wounds, and gastrointestinal tract patients. Patients with an immunocompromised system, especially phagocytic defense, develop occult lesions in the kidneys, skin, eyes, heart, and meninges. Systemic candidemia is associated with chronic administration of corticosteroids or immunosuppressive agents, especially in persons with leukemia, lymphoma, and aplastic anemia. Candidial endocarditis can occur when there are deposition and growth of yeast pseudohyphae on the heart valves. Systemic candidial infection can also occur associated with urinary tract infection in persons with Foley catheters, diabetes, pregnancy, and antibacterial antibiotics. Chronic mucocutaneous candidiasis. It is a rare form of candida infection that normally starts in early childhood. It is associated with cellular immunodeficiencies and endocrinopathies, causing chronic superficial disguring infection affecting any areas of skin or the mucosa. Chronic mucocutaneous candidiasis affects effective Th17 immune response. Let's discuss disease cycle. On the fungal colonization on the epithelial lining of the host, the fungi acquire nutrients from the lining and its cells, providing a suitable platform for growth. They cause superficial infection by degrading the surface proteins, and if there is no prompt treatment, the infection persists into the tissues. Invasion of the tissues can affect the vascular system through the spread and escaping immune interventions. The disease then disseminates into the endothelial tissues of various organs, causing disseminated diseases. History and physical of the candidiasis. The patient with vulvovaginitis may present with intense itching and irritation in the vagina and vulva and a burning sensation with urination, which can be mistaken for urinary tract infection, vaginal soreness, a pain or a dry erythematous rash, and a thick white cottage cheese like discharge. Candida also presents as an oral infection called thrush, which is white or yellow non-scrapable rash on the tongue and mucous membranes of the mouth, or redness and soreness with cracking at the corners of the mouth. It causes pain with swallowing when it extends into the oral pharynx. It is common in infants, the elderly, and the patients with a compromised immune system. Systemic candidemia causes fever, chills, hypotension, and confusion. Laryngeal candida infection is a rare condition. It predominantly presents in females. They usually complain of dysphonia. It largely correlates with gastropharyngeal reflux or a history of usage of inhaled corticosteroids. Glottis may be affected by the presence of leucoplastic lesions. Differential diagnosis. Spongiform pustulation can also present in pustular psoriasis, subcorneal pustulosis, acute generalized subcorneal pustulosis conditions. Hence, special stains should be used to exclude fungal etiology in psoriasis. Impetigo also shows spongiform pustulation. Bacterial colonies in impetigo may be seen by using gram stain with GMS, and PAS stain will not stain fungal forms. Spongiform pustulation is a characteristic of Tinea crudis, a corporis. Special stains reveal septate hyphae without the budding yeast of Candida. The distinction can occasionally be challenging. Candida usually infiltrates the keratinized epithelium, whereas dermatophytosis usually involves only the stratum corneum. The correct diagnosis of laryngeal candidiasis is difficult for the otolaryngologist, and high level of suspicion is in order. This condition should also be part of differential diagnosis in patients with predisposing factors presenting with suspected lesions. Let's discuss laboratory diagnosis, which is very important. You have to write in candidiasis. Specimen and specimen preparation, oral swabs and scrapings from lesions, vaginal swabs, blood, spinal fluid, tissue biopsies, urine exudate, intravenous catheter materials are used. Spinal fluids are prepared by centrifugation. Microscopic examination involves using tissue biopsies, centrifuged spinal fluid, tongue and mouth swabs, and scrapings. Examine the specimen by gram staining for identification of pseudohyphae and budding cells. Skin or nail scrapings can be analyzed by using KOH wet mount and chalcofluor white dye for observation of the pseudohyphae and formation of the jump tube. In this picture you can see the gram staining of yeast and hyphae. This is KOH mount, and here you can see germ tube formation. Cultural examination. The specimens can be examined by culture methods using fungal media or bacterial media at room temperature, that is at 37 degrees centigrade. The basic culture media used in isolating clinical candida species are blood agar, potato dextrose agar or broth, Seborrheic brain heart infusion agar, Seborrheic dextrose agar or broth, yeast nitrogen base, and yeast potato dextrose agar or broth. Least synthetic media can be used for mycelial development and yeast formation for the Candida albicans. Other media that can be used as a selective or differential media are chrome agar, Candida candiselect 4 and Pharmadia. Pangolevin agar can also be used as a differential medium, but the presence of triphenyl tetrazolium chloride (TTC) was found to inhibit the growth of some species of Candida. The colonies are examined for the formation of pseudohyphae or chlamydospores. A 10% KOH wet mount after culturing is used for the identification of pseudohyphae and the germ tube formed by the Candida albicans. Candidemia is primarily diagnosed through blood cultures. Treatment of candidiasis. Candidiasis is treated with antifungal drugs such as clotrimazole, nystatin, fluconazole, voriconazole, amphotericin B, and echinocandins. Fluconazole and echinocandins are administered intravenously. Caspofungin is used for the treatment of immunocompromised individuals. Localized infections such as mouth and throat candidiasis can be treated with topical medications and oral antifungals. Candidal skin infections are treated with topical antifungal treatments such as nystatin and miconazole. Gentian violet is used to treat oral thrush in breastfeeding babies and topical miconazole for breastfeeding mothers with breast candidal infection. Esophagitis candida infection can be treated with oral or intravenous amphotericin B. Vaginal candidiasis is treated with topical antifungal agents, majorly fluconazole, imidazole, or triazole, some using vaginal suppositories or medical dutches. This can also be done during pregnancy. Candidemia can be treated orally or intravenously using fluconazole, candin like caspofungin, and also amphotericin B, which is can be used. Prevention and control. Maintain a healthy lifestyle to reduce the overgrowth of Candida albicans. Good hygienic practice such as brushing teeth, bathing, hair care, food hygiene, hand hygiene are important. Proper nutrition, very important. Careful use of antibiotics. Please like, subscribe, share and comment. Thank you for watching.